For the next agenda, this is the third symposium. We will deliver 3 topics presented by the first one by Professor Victor Sihu from Malaysia, University of Malaya. And then the second one, it will be presented by Dr. Rapeepun Jommaroeng, PhD, MBA, MPA, MA from Thailand, Mahidol University. And then the third one from Mr. Djamil SKM M.Kes from Indonesia. And the discussion will be led and hosted by Mrs. Ratri Setyamulyasari SKM. Before we start the third symposium, let me read the curriculum from Mrs. Ratri Setyamulyasari SKM. So she was born in Kediri on 20 September 1993, and she was graduate of Bachelor of Public Health in Institute of Health Science Strada Indonesia, and she is currently got awarded as the third speaker in National Health Seminar of HIV/AIDS in Pregnancy and Newborn, and she has experience as assistant nurse in pediatric ward of Female Rehabilitation Center Riyadh. And also, she has been teach for intensive English for specific purposes in International Hotel and Cruise Ship School of Neptune. And now she is being the Career Center of Language and Job Placement Preparation Department in Institute of Health Science Strada Indonesia. So this is the summary of Mrs. Ratri curriculum vitae, which I can read. Also, there are still many interesting and proud achievements that she has achieved. And to Mrs. Ratri Setyamulyasari SKM, time and place are yours.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. To the Honorable Professor Dr. Sandu Siyoto, SOS SKM M.Kes as Director of Institute of Health Science Strada Indonesia, to the Honorable, the second, the third, and the fourth counselors of Strada Indonesia Health Science Institute, to the Honorable of the first, the second, and the second keynote speaker in the third session of symposium, and also to the Honorable, the active, and also the passive participant of Strada International Conference on Health. First of all, I would like to invite Professor Dr. Victor Hu Chiwai bin Abdullah as the first keynote speaker in the third session. But first of all, I will read also the biography and also the academic qualification of Professor Dr. Victor. He is a general physician with a practice in the University Malaya Medical Center and teaches at the Department of Social and Preventive Medicine. The latest qualification of education, he graduates from a PhD program at the Monash University, Australia at 2013. And also he is the webmaster for Asia Pacific Consortium for Public Health, APACPH. And the areas of the expertise for Mr. Victor is the epidemiology, environmental impact assessment, safety, health environment, public health, and also occupational health. The second speaker is Dr. Rapeepun Jommaroeng from Mahidol University, Thailand. The curriculum vitae is the current professional work experience. At 2019, he works as a lecturer at the Department of Community Health Faculty of Public Health, Mahidol University. With the educational background, he has graduated from Master Degree of Business Administration at 2017, and then continued to the Master Degree of Public Health at 2019, and also being a Doctor of Philosophy, PhD in Demography, with the dissertation title, Effectiveness of National HIV Prevention Outreach Program for Men Who Have Sex with Men and Transgender Women in Thailand. And our third speaker today is Mr. Ahmad Djamil, SKM MM M.Kes. he graduates from Master Degree of Health Science in School of Health Science Mitra Lampung at 2011. And also the latest working experience is being a Dean of Health Faculty in Mitra Indonesia University. And he is also the chairperson of Association of Public Health and Professionals in Lampung Province at 2019 till present. Okay, I have read all the curriculum vitae for our first, second, and also the third speaker. Now let's invite Mr. Dr. Victor Hu Chiwai bin Abdullah as the first speaker to give the explanation about the topic prevention practical steps and SOP in the time of COVID-19 back to work safely. To the Honorable Professor Dr. Victor, time is yours.
Thank you very much. I'm going to share my slide. I want to see whether you can see my slides or not.
Yes.
All right.
I have already seen this. Yeah.
Okay, thank you. Right. Good afternoon, everybody, and thank you for inviting me for this second Strada International Conference on Health. All right. So today I'm going to present prevention of practical steps and standard operating procedure, time of COVID-19, back to work safely. Basically, this is from what we experienced, what we have done in the University Malaya Medical Center since the start of the COVID-19 pandemic in November and December 2019. So this one basically when we started to consider or to take action is on the 6th of January 2019. Then on the 25th of January 2020, we have our first case of COVID-19 in Malaysia. And University Malaya Medical Center actually received their first PUI, or patient under investigation, on the 25th of January 2020. So on the 26th of January 2020, on the second day of Chinese New Year, we actually have to come back. It's a public holiday but we have to come back to actually start the working committee so that we can basically ensure that COVID-19 is taken care of in University Malaya Medical Center. So basically this shows that from the 26th of January, there was 4 confirmed cases. Then we have basically the second, we have started COVID on the 18th, started our MCO, our lockdown on the 18th of March 2020. So what do we know? Basically, to start with, you must understand that by having the basic knowledge of public health and also of occupational health, you can actually prevent the spread of the disease without actually knowing so much about the disease. So, but we know that to start with, we know that the hazard identification is a coronavirus, and all cases are imported. The risk assessment, we know that it's spread by droplets and aerosol. At the time, we know that there's no asymptomatic patient. So by knowing this, basically, we would be able to continue and see what kind of risk control measure we can take. All right. So on the 18th of March 2020, when we have 790 confirmed cases, recovered 60 and death 2, that's when Malaysia actually implemented their lockdown, or what we call movement control order in Malaysia. So identification and management of effective control. What is control? So a control is basically either prevent or the release of hazard or mitigate the consequence of its release. So identification and management of effective control. What is control? Basically, we must identify the source of the virus, and then we must know how does it spread and who actually are more at risk. Basically, the question one of your participants asked is whether children are more at risk compared to adults. Basically, there's no difference between the children and adult getting COVID-19. All right, it's just that children are not it's not so the symptom in children is not so severe compared to adult. So the source of the infection, we know that at the start is basically most of the people coming back from overseas. So there was no local transmission. So by that, by identifying the risk early, basically, and also when the risk changes, we need to know how to manage the risk. So the basic thing that you need to understand is the hierarchy of control. So hierarchy of control actually can be used in these circumstances, also in any other circumstances that is related to risk assessment, hazard identification, risk assessment, and risk control. So the most effective control measure is basically by elimination, all right, substitution, engineering control, administrative control, and by personal protective equipment. But in the case of basically biological hazard, we know that the elimination and substitution is not really a matter of control that we can implement, because we cannot eliminate the virus when the virus is already present in the community. All right, there's no way we can substitute the virus for a less hazardous virus. So the only thing we can look at is engineering control, administrative control, and personal protective equipment. So being a public health specialist, being a public health physician, or being occupational health practitioner, you need to understand what is engineering control, what is administrative control, and what is personal protective equipment. How do you basically control this and move forward? So by engineering control, basically what we are doing is we are trying to control that the transfer from the patient and transfer through the path and to the person. So what we're trying to control is control the path of the transmission. So one of the engineering control measures that we have in Malaysia is basically looking at confined or isolated work process. That means we try to either we confine the patient or we confine the workers. In this case, you will see that there's what we call an isopod or isolation pod to use to transfer the patient. And also you see the workers are basically isolated by themselves using what we call a powered PAPR, powered purifying respirator. So we also design an engineering control when we look at identify area where the hazard is basically very high. You look at this, basically it's called intubation, or we're trying to put an endotracheal tube into the patient. That is basically will generate a lot of aerosol. So when aerosol generation, that is basically very, very hazardous, and the issue is that we need to identify to make sure that the hazard doesn't spread. So to limit the hazard of spreading, basically we thought of designing what we call aerosol box. So so the procedure is performed within the box, so that the healthcare worker outside of the box is not basically getting exposed to the hazard from the patient. So this is a form of engineering control. So another way of engineering control is doing a confining or isolation process, where we isolate the patient, either isolate the patient or isolate the workers in a booth that doesn't allow the spread between the area. Firstly, you must understand that all these things happen at the early part of the COVID-19 pandemic. All these things happened is around March to April, where everything was still very fluid and the understanding of the pandemic is basically not really clear. But because we have understand the basic of control measure, we are able to implement all these control measures without understanding the full extent of the disease. The other way is engineering control of confining workspaces is basically to ensure that the workspaces is isolated from other workplaces. So if you can see, this picture actually shows our emergency, one of our emergency ward, where the emergency ward is very open. It was designed like that so that to allow basically observation from afar to make sure that the patient with affected are protected, basically are taken care of immediately. But the problem with this type of arrangement is that when there is an aerosol, the spread of the aerosol is basically very, very fast and very, very not efficient in control the aerosol. So what we did is basically we built a temporary structure using just basically plastic sheet, and to ensure that the aerosol generator is maintained within the room so that people outside of the room won't be affected. So you don't have to wear PPE when you are, wear 100% PPE when you're outside the room. This is all this, if you see here, are basically plastic sheets, all right? All these are plastic sheet, and these are plastic sheets. And this one, basically, there is a runner up there, or something like a curtain rail where they basically you can pull out, open, and it's like a sliding door. All right. So we designed this to make sure that the thing happened. Why we did this? Why we use this type of practice instead of putting permanent structure is that during that time where we are basically in MCO or movement control order or lockdown, where a lot of our activities are basically limited. So to get this equipment is basically very difficult, and so to do it quickly, basically we did this, and there's one of the engineering control measure that we use. The other engineering control measure is basically we built what we call isolation between two different sections of the ICU. This is basically a picture of our ICU where we built two temporary doors. One side of the ICU we consider a clean ICU where we don't have a COVID patient, and the other side of the ICU we consider a dirty ICU where there is COVID patient. So for workers to basically come from one side to another, they need to go through a door and before they change, and then they come out again, so that basically you won't contaminate the clean area of the ICU or intensive care unit. So this is how the ICU, how the door actually have when it's completed. And then this is where inside a room between the isolation where the workers actually change. All right. We also install a HEPA filter outside the door in the clean side to basically ensure that all the air are basically clean before it allows to go into the other room. So this HEPA filter, you must understand that if you want to install a HEPA filter, the grade of the HEPA filter must be H14, basically being able to filter 99.97% of the 0.3 micron particulates. So although the coronavirus is 0.1 micron, but the virus itself 0.1 micron, but the aerosol itself basically will be around 0.3 micron. So this is what we did. This is the This is the clean ICU. This is a dirty ICU. So we have what we call donning, where we basically put on our PPE or personal protective clothes, and then we go through an empty room. That means a room where we're supposed to be not isolating the air from one room to the other, and then basically we go to a dirty ICU. All right. But before we come out, we basically go through a doffing area where we take out our clothes, and then we go back to the other room. So this basically why we can do this is because the two sections have different air handling unit. So the issue that you need to understand air handling unit also as a part of a public health practitioner. That means how the air actually flows between the certain areas. Although these are in the preview of the what we call engineering, but because I have a master's degree in Master of Engineering, Occupation Safety and Health, I'm able to understand this and basically combine the two specialty of medical, public health, and also engineering, be able to advise on how to come up with a system that is useful. All right. So the other thing, more important thing is in engineering control, you need to understand the ventilation system. All right, you need to understand how air actually come into the room and how actually goes out of the room and how air is actually processed in the room. So what is required in a ventilation system is that you need fresh air, and you need to ensure that there's no airborne hazard. And you need to maintain basically either heat or cold, and you need to ensure that the humidity are maintained. So all these things are important when you talk about an air handling unit or talk about air control within a room. All right. So what are the ventilation system available? So basically, most of the time we have what we call a general ventilation. So in a ICU, in a normal room, we use a general ventilation where small quality of airborne hazard hazard release at uniform rate, sufficient distance between workers and source of hazard, hazard at low toxicity, no need to filter before discharge, and non-toxic to the environment. So this is what we use when we talk about airborne hazard, when we related to biological hazard in either a ward or a hospital. We don't use what we call local exhaust ventilation in that extent because the hazard is not concentrated. The hazard is present everywhere. So we still need to use general ventilation. So when you look at the general ventilation, we have what we call a centralized air condition, all right? And also we have a split air conditioning unit. So how does a centralized air conditioning unit works? We must understand that for us to be able to understand how the air flows between the area and how do we ensure that everything is present, all right? So there's cool air. So the cool air will go down, all right? And then cool air is heavier, all right? So cool air will go down. When the cool air becomes warmer, that's where the warm air will go, stays lower and the warm air will go up. All right? And then, so the outdoor air will come in and then you go through a filter. So cool air will stay inside the room. And then when the hot air comes, the hot air will go out. And basically this is what we call general ventilation, where the general ventilation is basically, this is yes. So this is where we, not a split aircon unit, this is a centralized aircon unit where basically the air is basically clean. So there is a filter here. You will see there's a filter here. This filter is basically can be a HEPA filter, all right, where basically you can clean the air. So in a room where there is a centralized air conditioning unit, we have basically bring in fresh air, all right? So fresh air. So basically what we need to understand is how many air exchange per hour. So usually the air exchange per hour for a normal room, which is basically not a hospital, is 4 times an hour, all right? For hospital, which is not a high risk area, is 8 times an hour. For a high risk area like your operating theater, your ICU is 20 times per hour. The higher the number of air exchange per hour, the more energy you need for that to function, all right? So that's important, you need to understand. You cannot just say, I want 120 air exchange per hour. That is not allowed because then you will have a problem, all right, of high energy cost. This is what we call a split air conditioning unit. A split air conditioning unit, if you look at it, you must understand that the air actually does not come in from the outside. So there's no air exchange. There's no air exchange there's no fresh air coming in. Or when you're in a room where you are basically using a split air conditioning unit, the air inside the room actually stays inside the room and doesn't go anywhere. So if you look at it, if there's a contaminant in the room, it stays in the room and does not go anywhere. So that's the problem that you need to understand, and that's why some of the earlier people talking about there is a spread of COVID in the room is because sometimes they don't understand how air circulate and how much air exchange you need per hour to actually ensure that the air is clean. All right. So the other thing about ventilation system is that although we have what we call a centralized air conditioning system within a hospital, there's 2 types of airflow that we look at. Basically either a laminar airflow or a non-laminar airflow. A non-laminar airflow is basically when the air flows in a circular manner and actually the cool air stays down and then it basically only when it becomes warm, it goes up again. This is a normal airflow. Why we use this type of airflow is because this is basically more energy efficient. It means when the air is cold, it stays in the room. It doesn't go anywhere. So when it's become warm only, it basically leaves the room. So your cooling is basically much more efficient compared to when you're talking about a laminar flow. If you look at this room, this is a laminar flow. This is what we call a outlet. All right, and this is basically where the air comes out, and this is where the air exits. All right, so this is the outlet and inlet. So the air actually flows like that, flows to the room. So in an operating theater, all right, if you see the picture, cold air will come in, fresh air will come in from the outside, cool air will flow through two HEPA filter. This is one HEPA this is called pre-filter. Then we have one HEPA filter here to ensure that the air is clean, and then before the air actually goes out again. So this one in this room, in the OT room, basically we have a 20 air exchange per hour. The other thing we need to understand that a lot of people say negative pressure room is basically safe. Negative pressure room is not safe in the sense that if it's not laminar flow. So that you must understand, if you have having in the negative pressure room, the contaminant stays inside the room, people outside the room is safe. But if you go in, you are not safe. All right. So the ventilation system, you need to understand that there is a negative pressure room. So this is a good negative pressure room where the fresh air comes in from the outside. It goes into the empty room where basically you change. Then it goes into the patient's room. Then from there, it goes to the toilet and then it goes out. So the air actually flows one side. It does not mix around inside the room. All right. So this is what happened. The air will come from here. It goes all the way and comes out through here. So this is a good design in the sense that fresh air is clean air. It goes to the patient's room and then it goes into what we call in the toilet where it is filtered before it comes back again. All right. When there's a bad design, when the pressure within the room is actually not that what we call, there's no positive. So the air actually stays inside this room and then it will become a problem when you're talking about a negative pressure room. So to overcome this, basically we'll look at whether we can install a HEPA filter or not. So what we do is we install HEPA filter where we think that the risk is high for transmission. And the HEPA filter is basically a filter with a grade of H14. So we have a lot of HEPA filter everywhere. We install HEPA filter everywhere to ensure that if we cannot control the flow, if it's not a laminar flow, then we need a HEPA filter. Because we need to clean the air, because we know that the air is basically turbulence inside the room. So if you are, let's say if you are in the clinic where you use basically a split air conditioning unit, the problem with the split air conditioning unit is that you would get, if the patient is basically having COVID, the doctor will get the COVID. All right. So the other way of looking at it is that you shift your way you sit inside the consultation room, where you sit behind the aircon, so the air will flow, the fresh air will come in and then will flow through the room, and then basically you would collect to a HEPA filter, so the air becomes clean, so you won't be affected by it. All right. So the HEPA filter, we're talking about H14 or E14, where you can basically filter 99.975% of the air. That is the minimum you want to have. You were talking about ensure that the filter is safe. So the other one is administrative control. All right. So we have administrative control procedure that minimize exposure while operating production and control equipment, control of employee exposure by scheduling production and workers tasks and both in ways that minimize exposure level, conduct hazardous procedure during time where there are less workers, rotation or job role, right? So what we do in the user medical center is we do temperature screening, all right? Physical distancing, at least 1 meter, good hygiene, good supervision, good housekeeping procedure, mandating drinking, smoking, chewing tobacco, apply compensate in regulated area to be prohibited. All right. So that's what we did. We say do not enter. Patient is patient in progress. COVID patient in progress. So we have a separate administrative control. We ensure that the patient coming into the hospital, we screen them before actually they come into the hospital, so that the workers in the hospital know whether the patient is at risk or not at risk, or is it a patient under investigation or not. So we have a separate zone outside where we do the screening. So outside screening is much better because there's no, you don't need to control your artificial air. Basically, you have natural air. We have basically what we call use a separate area, and also have distance to increase the distance. All right, temperature control. All right, and personal protective equipment. But when you talk about personal protective equipment, we need to understand the correct personal protective equipment to use and when to use it. Of course, it's the last option, but we need to use personal protective equipment when we're handling biological hazard. All right. Why is the last option? Because the use of personal protective does not reduce the hazard. If the risk of PPE fails and a failure is not detected, the risk increased significantly. All right. Why PPE is not a matter of choice? Because it's a sometimes failure where PPE, particularly for the one-off quick job or take the attitude of it is you'll be okay, right? So people believe that they are safe when they are wearing personal protective equipment. So what we call a false sense of security. So choose a personal protective equipment as the first choice is appropriate and shift the responsibility from the employer to the employee. So what are that? What do we have? We have basically what we call protective respirator PPE, particulate or vapor, mist, gas, and oxygen deficiency. So we are basically operating on the principle of purified air or supply air. So what we do during the COVID crisis is basically we use purified air. All right. So air purifying respirator, particulate, gas, vapor, canister, cartridge, powered and non-powered. So we will not focus on this. So what we basically we are talking about, we are talking about most of it is particulate respirator. So when you look at this particulate respirator, you know that some of it basically is a full face. This is a half face, full face, and this is just this is also a half face. All right. So some of it have a valve and some doesn't have a valve. The problem with basically having a valve is that it is a one-way valve where the person who's wearing it will contaminate the area. So for clinical area, we don't recommend using a valve respirator. All right. This is just to tell you the different type of respirator. We have N, R, and P. N is non-oil. So the important thing is that basically you use the non-oil is adequate. And this is what we call a PAPR or powered air purifying respirator, where you have a power here to actually pump air into the area so that you can have a more fresh air. So this powered respirator contains HEPA filter in this area. All right. Okay. So even the what we call the respirator face mask, we have different kind of grade. We have level 1, level 2, and level 3. So we have a lot of people donating what surgical mask to us. So to ensure that the surgical mask that is used is basically adequate protection, we ensure that we only look at level 2, US ATSM or European standard type 2. So the surgical mask basically must be at least level 2 or type 2. And the respirator must be at least KN, it can be N95 or FFP2. So the issue that N95, K95 of FFP2 is what the level that we are looking for when we make sure that the respirator that we buy are adequate. Right, this is to show that different countries have different standard. So the standard that is basically same as N95 is your FFP2, K95, P2 for Australia and New Zealand standard, Korean standard, and also Japanese standard. So this basically show different standard. All right, and what is the difference between the standard? So so ATSM is basically not a surgical mask, cannot be used in a surgical clinical area, but you can use it for if you're using it outside the clinical area. All right. So the minimum standard is basically ATSM level 2 so for a clinical mask. All right. And N95 respirator is basically protect against residual surgical smoke patient with known or suspected.
Professor Victor, you have a limitation time because actually for the presentation only 20 minutes.
Okay. All right. I'll finish already. Thank you. All right. So thank you very much. Yeah. Okay. Thank you.
Okay, thank you for the Professor Dr. Victor for the very nice presentation. He combined two sciences between engineering and also occupational health. And now for the second session, let's welcome our second speaker from Untitled University, Thailand, Dr. Rapeepun Jommaroeng.
Oke, selamat siang dari Bangkok, Thailand. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Selamat siang.
And that would be all Indonesian that I know of. So let me try to share the slide from my side. Maybe perhaps the you could see it as well. Okay, all right. So basic, but I should warn you that today I think the administrator warned me that there would be a 5 drill in the building. So if you see me running away from the screen, it means that I have to run for the fire drill. Okay, but anyway, hopefully not. Not right now. So I'm going to take you a little bit away from the some of the medical approach to back to the policy, because that's where I'm actually my expertise lies in. And recently, I just came back from the what we call a seminar on Thailand global health strategic planning. So that so you are actually the first group of audience that that have heard from me actually before our Thai audience as well. So for this one, let me take back to the our global health approach, global health approach development, and I'm using the collaborative governance to actually give you some ideas about how we would like to move forward to the global health. Because you know what, when we talk about global health, we usually have the different ideas about what global health should be and how can we make make use of it. So so for example, in the idea of what does global health means to us? Well, first of all, we need to understand the causes and consequences, right, of health concerns. I think everybody here in this conference understands this one. But the second thing is that it goes beyond the medical approach. So we have to make connections between economics, politics, biology, medicine, sociology, psychology, and so on and so forth. I think that the COVID-19 gives you a very good idea whether you should lock down your cities and then, and then jeopardize your economy, or you still open your cities to maintain your economy, but at risk of the COVID-19 epidemic. So you have to balance that. It's not always the one or the other. And the next thing is we need to learn from others about the effective and ineffective responses to critical problems. And I think that you have heard the presentations from all the speakers today as well. And the last thing that we need to know is, do we want to make sense the complexity of the 21st century of life, right? So, but you know what? This just only the basic principle. But many people don't have the same idea. But I'll explain to you later on. But you know what? In terms of global health, different countries make use of the different approach. For the next one, there are some studies from the way that people or each country make use of their global health. In Brazil, they use their slogan is right to health, or basically the country's slogan is O País para Tudo. It means country for all. But you can notice that Brazil would be the only country that speaks Portuguese among the countries that all speak Spanish, right? So they want to make friends. So they use the global health approach or global health strategies to finance health programs in the Latin American and the Caribbean countries to make friends and establish partnership. You see, that's how they use it. But in terms of China, you will see that they use a different approach. They aim for the economic growth and expansion across the world. And you can see a lot of great examples in Africa, particularly because 80% of their fundings on health issues go to Africa. So you will see quite a number of buildings and infrastructures that has some kind of Chinese signature in the middle of African continent. For example, some kind of the building that has a very Chinese architecture around that looks a little exotic. So, but anyway, they have some kind of the trade deal with the African continent. But in terms of South Africa, they use the global health to respond to their own country problems, including HIV, malaria epidemic, right? This is just to learn from the successes of other countries in order to solve South Africa. But by doing so, they can be the learning site for other African countries as well. So now you see the three different approach already, right? For the United States, they want to make the better health for development by extending partnership across the world. I think you already know that USAID, they give a lot of funding, maybe not nowadays, but previously they did that. But for Thailand, since we're not exactly a rich country or a big country, so we want to take the leader role in the medical and public health field. So basically, we want to show that what we have done so far, like for example, in the COVID-19 example, that we did a lot of the public health measures so that we can control the epidemic within the country. And now we don't have much of the lockdown in the city anymore, but international travels are still banned. So why am I talking about this? So let's get to, when we want to talk about global health, we usually think about that this is the matter of WHO, but actually it can be for us within the country. So last week, there was the workshop that the different partners in Thailand attend. This is a lot of too much text, but I just want to point out that there are people from the Ministry of Interior, Ministry of Foreign Affairs, Ministry of Digital Economy and Society, even Ministry of Natural Resources and Environment attended the Global Health Seminar. So the first question is, what do people from the Ministry of Interior or Home Affairs need to do with the global health? How can you involve them? Because you need them, actually, you need them. And you can see that a lot of other people who are from the non-public health sector. So they were, on the first day, they were puzzled, like why were they invited to attend the global health conference, global health seminar? What should they should, how should they can be part of this kind of global health development? They had no idea. So the first thing in the meeting that they would speak out is that I'm not from the public health field, so I'm not sure what I'm supposed to be doing here. Now you can see that people make excuses that they are not part of this meeting or this working group already. So you will be losing people along the way, right? So, and in the meeting, we proposed one strategy. We call a vision. We said that a healthy world through global health. This is for Thailand. But are you noticing something? That whether this one is more appropriate for the World Health Organization or this is more appropriate for Thailand, right? So you can see that this is for the whole world. So will Thailand be able to do this for the whole world? Maybe we cannot. So what is left for the global health strategy for Thailand? How can a country make use of this global health? And who should be involved? And how can they involve? And the last thing is, will they actually involve meaningfully or whether they're just invited guests in the meeting? Because in the meeting last week that I attended, most people would say that they are assigned by their Permanent Secretary General of the Ministry of Interior, by the Ministry of Defense, by the Ministry of Human Resources, of the Natural Resources. So they had no idea what we'll be doing. So another one approach that can involve people meaningfully and engage people fruitfully is the use of the collaborative governance. So from this one, you can see that we have to make sure that we have the starting conditions first. First of all, we have to make sure that the first one, power and resource and knowledge asymmetries. We have to make sure that people from the many different ministries or different sectors have the same understanding of the global health and why it matters to them. So in that conference, we didn't start with the strategizing anything at all, but we just asked people to talk about how they are affected by the health and COVID-19, which is a good example, right? And then we make sure that people are on the same page first. And the second thing is that we need to make sure that we have the no prehistory of conflicts, because when we any organization working together, sometimes they didn't get along. So we have to make sure that we solve that problem first. And plus another issue is that we have to make sure that people know the benefits or incentive for participation. Okay, I can give you one example is that in Indonesia, you have a very good work in harm reduction, right? Better than Thailand, I would acknowledge that. But in Thailand, it's more problematic because the government want to eradicate all drug use, right? Why NGO or the civil society said that, well, people should be able to use drugs because it's their rights, but as long as they're safe from HIV and then they comply with the harm reductions. So people have different ideas already. So can they be on the same table or not, right? Can we reach the destination? Maybe not. So this collaborative governance process is useful because first of all, we need to have the face-to-face dialogue. But when it comes to face-to-face dialogue, we need to do good faith negotiation. So you have to make sure that people actually get benefits. You know, in the global health meeting, the foreign affairs will get the benefit in terms of the trade negotiations with certain countries, right? And in terms of the Ministry of Natural Resources, it means that we do trades with other countries as well. In terms of public health, we can do a good work or showcase to other countries in the way of the South-to-South collaboration. So we need to make sure that each single actor know their benefits and then that agree upon to meet with each other. And the next step is that we need to build trust. Because most of the time in the public health sector, we invite people from the non-public health sector because we think that we should involve them. But anyway, eventually we will hold the responsibility within the health sector, not giving out the responsibility to other sectors. So people don't feel like they belong to the process. So that comes to the next process that we need commitment. So we need to make them commit to these global health issues by, first of all, mutual recognition of interdependence. It means that we have to show that we need the Ministry of Foreign Affairs. We need universities. We need different partners. If we don't have you, our strategies won't be successful, won't be able to implement it successfully. So we have to show them that. Otherwise, they would feel like they are just, the tokens in the meeting, and that's it. And then there's no continuity of the process. And the second thing is we have to share the ownership process. So mostly it means that we need to have something that the people can own things together. In terms of the global health, we need to divide the responsibility. So if you talk about the global health and then people just assume that this is the public health issues, then they're not going to be interested and they won't come back again in the next conference. And also we have to open for exploring mutual gains. We have to understand that other people, Minister of Defense, I give you, they're very Thai people, right? So right now, Thailand is buying submarines from China. So we have amidst of the COVID-19 epidemic in the country. So most people think that the government or Minister of Defense shouldn't use the money to buy submarines because who to fight with? Are we going to fight with Malaysia, Cambodia, Vietnam? Come on, right? So we don't, but we don't know that. So we need to invite them into the circle to ask them about what their hopes and they want to achieve and how can they be part of the health issues in terms of budget allocation. So this is very important. And the next thing that we need to do is to share understanding and clear. So we need to have the clear mission and common problem definition and identification of common values. But the thing is, when you have different partners, you need to have a very strong leader. For example, in Thailand, in terms of the harm reduction, we could not agree upon the final destination, where we want to go, right? So we have one facilitative leader from the universities, and then they are what you call the neutral partner to balance between NGOs and also the government policy. So basically, we use what we call intermediate outcomes, what we call small wins. So we don't know where we want to go in terms of harm reduction or even the global health strategy right now. Giving example, it's more like I want to go to Indonesia, but I'm not sure whether I want to go to Jakarta or I want to go to Bali. But this facilitative leader says that, okay, maybe we don't need to talk about the destination as long as we get on the plane. And now we agree to have the small wins. Let's say that the plane, we have to fly over Kuala Lumpur. And then that's where we're aiming for. But after Kuala Lumpur, we will continue our discussion later on whether we want to go to Jakarta or we want to go to Denpasar, right? So as long as we are on board. In terms of harm reduction or global health as well, we want people to go on board first, and then we try to develop further strategies if we cannot agree upon the destination. And then we have the clear outcomes. But before that, we need to make sure that people have the inclusiveness of the forum. Most people, when they go to the policy forum, they will talk about many different things. Like, for example, if we talk about global health, people would bring the issues about the submarine of the Ministry of Defense, COVID-19, economy, democracy, and everything. So we have to make sure that they talk about one exclusive topic at a time. Because if you bring every issues across the country, you're not going to achieve anything at all. And we have to have the clear ground rules and also process transparency as well to make sure that people are on the same page and they are connected to their superiors. And then that goes out to the outcome. So basically at the end, what we have is we don't have any vision or mission at all. So the strategies that we want to move forward from the 2021 to 2027 is that the first of all is we need to strengthen the staff capacity on global health. So they need to understand what global health means to them or means to the country or also in the region. So this one for us, the university, we know that we have to improve our teaching curriculum to ensure that we include the global health issues in our school teaching. And then we need to strengthen the governance of the global health in Thailand. So basically, when we conduct a study in Asia, in ASEAN, we barely see the global health strategies in other countries in ASEAN. I think they do some, a few countries in ASEAN, they do have this. But anyway, but we haven't used much of the potentials of the global health to the highest level, right? And the next one is probably we should talk about the advancing the global health knowledge and exchange it within the global community. So I think that in this conference is a very good example that you have learned from Taiwan, or your colleagues from Taiwan, and so from Malaysia about how they deal with the COVID-19. But in terms of global health, you have to understand that any countries that are badly affected by the epidemic or pandemic, it will affect the rest of the country as well. So this one is a common knowledge. So this is why that the global health has become a very important issue in our region. And the next thing is we're talking about strengthening the management system to implement the program of the global health. And also the last one is the national and international collaboration on global health development. So you will see that these, all of these strategies, they look very simple, very plain, right? Because we cannot agree upon the vision and mission at the moment. So we said that, okay, why not agree that we will go on this one? It's like we want to fly to Indonesia. And now we agree that, okay, let's fly over Kuala Lumpur first. And then when we reach Kuala Lumpur, we will talk about the next step. So in terms of the global health development in Indonesia, maybe there are two questions that, that you need to ask yourself. The first one is how could you make use of your global health in terms of the global health development in Indonesia? And the second thing is when it comes to different parties, how can you involve or engage people from the non-public health sector, right? Because in Thailand, we have a very less progressive in terms of harm reduction, but more progressive on sexual diversity or LGBT human rights. But Indonesia, it's on the contrary, that it's a little difficult to talk about sexual diversity, talk about waria, transgender, LGBT, right? So this collaborative governance could be one of the small steps that could be introduced to the Indonesia working group by giving the what we call the religious group, the public health, and also the people in the society happy so far before we move to the final destination. And that's all for me. So thank you very much. Terima kasih.
Okay, thank you very much for the presentation from Dr. Rapeepun Jommaroeng. As I can have summarized from the presentation, global health development is not only the responsibility for the Ministry of Health, but also the another ministry should be involved to have responsible to develop the global health. And that's what we call the collaborative governance. Okay, for the next session is the third speaker. We will invite Mr. Ahmad Djamil, SKM MMS M.Kes, as the third speaker.
Ini nggak kelihatan strategis agent stunting. Seperti ini. Stunting is a chronic growth disorder in children under 5 years of age due to lack of nutrition intake or malnutrition for a long time. In general, stunting occurs in toddlers, especially age 1 until 3 years. At that age range, you can see whether a child is stunted or not. Aduh, mana ini ya? Presiden Joko Widodo's pressure to accelerate the resolution of the stunting problem at the National Development Plan Consultation Meeting Musaimbang for the 2020 until 2024. That the National Medium-Term Development Plan, RPJMN, a few moments ago gave the arcane impression that the issue of nutritional status in Indonesia was still discreet. The message from the president also seemed to confirm that there was an unsatisfactory graphic stunting data in Indonesia. The latest data from the research cluster of the 2019 Indonesian Toddler Nutrition Status Study notes that the number of children under 5 with stunting in Indonesia currently reached 27.67%. Gimana ini? Gimana? Ya ini nggak mau. Indonesia is considered the country that has contributed greatly to the world stunting problem. Although the level of nutrition status of Indonesian society seems to be improved, this is not the case with the problem of stunting. If we refer to the 1913 data alone, the prevalence of stunting in Indonesia is even higher than other countries in South Asia, such as Myanmar, 35%, Vietnam, 23%, and Thailand, 16%. The high rate of stunting has negative implications for development and progress in Indonesia. Stunting threatens the productivity in Indonesia human resource because they are vulnerable to being attacked by various diseases. Nutrition literacy. Nutritional literacy is a determining factor in determining nutrition status in a society. Therefore, the first step in solving the problem stunting is to improve the level of the community's nutrition literacy. Whether it is realized or not, the problem of stunting appears not only because of malnutrition, but also because of public knowledge or information in understanding nutrition adequacy. Mas ini kok macet nih? Iya, digeser. Mana? Belum. Hilang. The government represented by the Minister of Health has issued a regulation number 25 of 2013 concerning the recommended nutrition adequacy rate for Indonesian people. But unfortunately, the kind of crucial information does not flow down to the entire community. There are faults in the process that cause many people to be unfamiliar with nutrition information. In addition, nutrition education material, especially on balanced nutrition guidelines, need to be widely introduced to all vulnerable groups such as pregnant women, to poor, and also school children in Indonesia. It's an urgency to conduct information literacy implementation starting from school, health facilities, and residence homes about how to choose food and drinks that meet nutrition requirement function of nutrient. Food access. Also, for a long time, the food and nutrition program has been a priority for the government through the 2015 until 2019 RPJMN, and also the 2020 until 2024. This does not mean to access to food in Indonesia is not without problem. Access food and further meaning as an ability of a community to have economic and physical resources to obtain nutrition food. The consequence of difficult access to food is it creates a chain hunger in the society. The 2018 Global Hunger Index relates a report stating that the hunger problem in Indonesia is already at an alarming level. This can be seen from the total score of hunger in Indonesia, which is 21.9. Ironically, Indonesia is even ranking 73 in the world when relates hunger problem. The low level of nutritious food consumption is a sign that access to food is still difficult. It's an important note for the government that access to food is a key factor in building a country and to be free from stunting problem. Therefore, increasing the ability of people to access food, especially for the poor, must be priority by to the government so that the enlightenment of stunting cases in Indonesia may occur immediately. Right on target, it's not utopian to imagine that Indonesia in the future will be free from the problem of stunting. There are many potential and resources that can be optimized properly to solve the stunting problem. Indonesia is a country with the third largest ecosystem diversity in the world after Brazil and Hong Kong. Indonesia has abundant marine resources. If there is no fleet and continue to use the same stance is dealing with stunting problems, then it means that all the effort made are fruitless. As a result, This condition will make Indonesia lose momentum to be able to leap forward to become a great country. Relates Journal, research conducted by Eko Setiawan, Risanda Mahmud, Masrul entitled Factor Association with the Incident of Stunting in Children at 24 until 59 months in the work area of Andalas Public Health Center, Padang Timur District, Padang City, and 2018 found that there was significant relationship between energy intake, history of infectious disease duration, birth weight, mother education level, and family income level with the incidence of stunting. Mother education level has the most dominant relationship with the incidence of stunting. Research conduction by Kukuh Eka and Nuryanto 2013 entitled Risk Factor for Stunting in Children aged 2 until 3 years, a study in Semarang Timur, Kusuma Subdistrict. The result of multivariate analysis show that the risk factor for stunting in children aged 2 until 3 years is family low economy, p-value 0.032 or 4.13, while birth length, parental height, and parental education are not the risk factor for stunting. They conclude that the family low economic status is a significant risk factor for the incidence of stunting in toddler aged 2 until 3 years children in family with low economy status. 4.13 times more likely to experience stunting. Research conducted by Melia Sari, Friska, and Isnawati, and Muflinah, 2014, and risk factor for stunting in children aged 12 months in Purwokerto village, Patipon district, Kendal district, show the result of bivariate analysis that risk factor and affect the incidence of stunting in children aged 12 months in the village of Purwokerto, where low birth length or OR 16.43, p-value 0.002, premature OR 11.5, p-value 0.023, and egg first feeding for OR 4.24, p-value 0.040. Low birth weight OR odd ratio 3.28, p-value 0.609. Duration of exclusive breastfeeding odd ratio 2.06, p-value 0.303, and breastfeeding score odd ratio 1.41, p-value 0.001. 7.7, not a risk factor for incident of stunting in this study. They concluded that the risk factor for stunting in children at 12 months, low birth length, short prematurity, and eggs at first feeding. Mercedes de Onis and Francisco Branca on childhood stunting. A global perspective mentioned that many more million suffer from some degree of growth, faltering as the entire length for its height for its z-score distribution is shift to the left indication that all children and not only those falling below specific cutoff at affect deposit global consensus on how to define and measure stunting of the
Yeah, excuse me, Mr. Ahmad Djamil, your time is up. Ya, Bapak sudah habis waktunya.
Okay, yeah, thank you.
Okay, so ladies and gentlemen, right now we will begin the question and answer session. I have already collect the question from the participant. So the first question goes
Yeah.
Professor Victor.
Gimana, Pak?
Yeah, hi, good morning. Good afternoon, yes, selamat petang.
Yeah. Afternoon. Yeah.
Oh,
So this is the
so
question for you.
I must also speak. Saya pun mesti bahasa Indonesia sikit-sikit, nanti malu saya dari untuk orang Thailand pula.
Yeah.
Ya, selamat petang.
Okay, so yeah. The question is, what symptoms that indicate patient COVID-19 need to be treated in ICU? And then how about the treatment? Is it mixed with another critical patient, or there are any separate room for isolation in the ICU?
So basically, when patient show symptom of respiratory distress, that means the respirating, they have difficulty in breathing, difficulty in respiration. So we would put them in ICU. So when we put a patient in ICU, COVID patient ICU, basically they are in a separate room. All right, ICU means each individual patient will have one room, and inside the one room there will be one nurse actually taking care of that patient. All right. So although we say that we put patient in ICU, not all the patients are intubated. That means we don't put tube inside the patient or let them to put them breathing in an artificial breathing. We have no intubation. We basically, what we try to do is to reduce the intubation, to increase the oxygen, to just give them more oxygen, and to increase the attention we give them. So all patient is isolated. All ICU patients are basically individual room, and we don't mix patient together. So usually what we do is we put a COVID patient, or not just COVID patient, basically a TB patient or patient with high risk of infection, we put them in a what we call a negative pressure ICU room. So basically they have a negative pressure with a laminar flow. I showed you just now a negative pressure with laminar flow and the one without laminar flow. So those rooms, we call it an isolation room inside the ICU. So that will basically prevent contaminant from going to another room within the ICU itself. So that's what we did. So, but because at one time we have a lot of COVID patients, that's why we separate the two areas. And we make sure that the air handling unit from one area does not go to another area. All right?
Okay, thank you. Thank you, Professor Victor. And then the second question, how to reduce the risk of COVID transmission with a full air-conditioned room, such as in a hotel or in an apartment, or in a house with less ventilation?
Basically, it's best to use natural air, all right, to allow fresh air to come in. You don't use aircon. You only use aircon when you basically if the room is very small and you use aircon, there's a lot of people inside, you will get infected if someone is sick. So the best is to open the door and have fresh air in the room. That's why it's practiced in a lot of clinics in TB clinic. If you I've been to Thailand. Malaysia don't practice that, but Thailand practice that. All TB clinic have no aircon. Basically, they're open air, fresh air. So fresh air is still the best. The problem with us is that we cannot stand the heat. That's the only problem. All right, but you can on the aircon and basically have fresh air. So the idea is that if you use a split aircon unit in your house, in a restaurant, there's no fresh air. So at one point, basically, I don't want to go to restaurant because I am scared of the air inside the restaurant. But if the restaurant use a centralized aircon, the risk is lower. But if the restaurant use a split aircon, the risk is very high. So the best is to avoid these places. And another thing you cannot avoid is basically to have fresh air and also stay away from because the air actually circulate inside the room. So if someone is sick, they will circulate to another person. So it's not good to basically be in an area where they use only split air conditioning unit.
Okay, thank you, Professor Victor, for the answer. So actually, the best is using the normal air.
Yes, the best is using fresh air from the outside. I think this one we know this so long, but the problem is we cannot stand the heat, that's all.
Yes, thank you, Mr. Victor. Okay, for the next question goes to Mr. Rapeepun Jommaroeng.
Okay, so I think that you're asking about how we can, detect the issue of the hidden agenda in the global health collaboration. I think this is a very good question. The first thing is first of all, you need to understand, to have the very profound knowledge about what is global health and what is not. So this is why the first strategy is you need to strengthen the global health, the global health knowledge among your medical or public health staff, so that they are aware that what is actually the true global health issues and what is hidden within the global health collaboration. So this is why face-to-face meeting or some kind of collaboration, even online like this, is very important, because you can notice from the non-verbal gesture. If you attend some kind of policy forum, you could see that when some people speak, you can be honest with them. But when another group of people speak, you have to be aware or be careful of what they want to say, because they always come with some kind of the hidden issues. So the best strategy is you need to map actors within your stakeholders, right? So you have some group of the people who you can trust, you can be honest with, and another group that you have to mark that, okay, when this country or this person speak like this, you have to interpret 3 steps further. So you have to be careful. This is diplomatic strategy, because when anyone will go to the School of the International Development, they are taught that when you give away one thing, you need to make sure that you have 3 things back in return. And people in the Ministry of Foreign Affairs understand this. So if you work on global health in one thing, let's say that the Professor Victor came to Thailand and then share his technology about the COVID-19 management. Thailand have to do some kind of the perseverance that what kind of the things that Malaysia would expect back from Thailand, like open border.
I'm not taking anything from you. Don't worry.
For example, but you can see easily that that when I start my presentation by try a little bit of the Bahasa Indonesia, now Professor Victor already sided with our Indonesian audience by speaking more advanced Bahasa than I can. So this is why when you go to the global health forums, you need to find partners. And this is why we have ASEAN, right? We have ASEAN. But within ASEAN, we have the Greater Mekong sub-region. So consists of Thailand, Myanmar, Cambodia, all the river flowings, because we speak less English than people in Indonesia, Malaysia, or Philippines and Brunei. So we cannot keep up with you guys, right? But on the other hand, you have Insula, Southeast Asian as well. So you have another group. So within the Greater Mekong sub-region, that's also Indochina. So you need to make sure that you have some kind of the coalition with the partner that you trust. And this is one of the things that you can take back. And also, of course, take the small wins rather than seeing the destination. And another question that I saw is that about how Thailand start the continuing collaboration with global health. This one we use what we call the soft power. You will notice that Thailand is trying to promote itself as the international hub for international organization, right? WHO, UN, all their regional offices are here. So we use soft power to influence them. Sometimes Thai people have a saying we call Thailand centric. So we try to think about Thai food is good, Thai food is the best, Thailand is the best, Thailand is the destination. This is all the image. So all the image. But anyway, doing that kind of soft power can influence, at the subconscious level of the international organization that we can advance this. And there has been many policies of the WHO that is already adapted what we have done in Thailand at the international level without being what we call the big power of the world.
Okay, thank you, Mr. Rapeepun, for the explanation to answer the question. But I have one more question for you about how effective this global strategy in reducing the spread of COVID-19 in Thailand.
Well, I think we responded very quickly, but there are two sides of the stories. But anyway, you are recording this conference, so I'm gonna have to select very clever words to say out. As you know, that Thailand has already promoted itself as a successful country in terms of containing the epidemic, right? But as the public health professionals, you have to ask the questions like, how many people do Thailand conduct the testing? Because if you don't conduct the testing, you wouldn't have the odds of the infections, right? So, but anyway, in terms of the global health, what we do is we learn quickly from the WHO and also the other countries, and also we know the big power in our region. For example, China. Sorry for our Taiwanese colleagues, but let's say that we learn from China how they respond to the epidemic, and we try to partner with them. So we have the doctors in China coming to Thailand because of course we want to please them, right? And then if we have any patients from China, we treat them until they are cured. And then it's being the big news in China in Baidu. So this is how we can use the global health to enhance the collaboration in the midst of the COVID-19. So you have to make sure that so going back to the collaborative governance model, right? You have to find the mutual interest of each country. We want to send our exports, our products to China, and China needs to be happy with us. They need to have people coming to Thailand. So let's do something about quid pro quo. So that's always a strategy.
Okay, thank you. So it's just like a win-win strategy. You get the benefits, and also I will get the benefits.
Exactly.
Okay, thank you, Mr. Rapeepun, for the answering question. And then the last question is for Mr. Ahmad Djamil. Okay, Mr. Ahmad Djamil, could you please unmute your microphone? Yes.
Yeah. Ini mikrofonnya mana itu, Pak? Sudah hidup?
Yeah, yeah, sudah terdengar.
Yeah. The government has formulated 5 national strategy to accelerate the reduction and prevention of stunting. Strategies to reduce the number of stunting. The strategies are complete through a comprehensive assessment and diagnosis process to determine the priority of activities to be carried out. The first strategy in this program is commitment and leadership vision. The step is to ensure stunting prevention is a priority from government and society at all levels. Its hope that the commitment and vision of the President and Vice President to accelerate stunting prevention and expected to direct, coordinate, and strengthen stunting prevention strategies, policies, and target. The second strategy in the strategy to accelerate stunting reduction is a national campaign, the behavior change communication. Through this second strategy, the government hopes that public awareness will arise and change in community behavior to prevent stunting. This is one of the key to the success of tackling and preventing stunting in Indonesia. The Ministry of Communication and Information in the Ministry of Health will coordinate with each other in implement this second pilot. The third strategy in this government priority program is a convergence of central, region, and village program. The government will strengthen coordination and consolidation of central, regional, and village program and activities. Convergent an approach to delivering intervention that are coordinated, integrate, and collaborative to prevent stunting toward priority target. The key, the success of this strategy is alignment of planning, budgeting, implementation, monitoring, and control of activities across sector as well as between level of government and society. The fourth strategies to accelerate and prevent stunting is food security and nutrition. The government will increase people access to nutrition, food, and promote food security. The government will encourage the strengthening of policy to fulfill the nutrition and food needs of the community, including meeting the food and nutritional needs of the family, providing food and supplementary food assistance, investment in product development, innovation, and food safety line with the mandate of law number 36 garing 2009 on health and law number 18 2012 about food. The fourth strategy is monitoring and evaluation. Monitoring and evaluation is an effort to ensure that work is being carried out actually goes according to what was planned. The government will ensure the provision of quality service in the community and increase the accountability of program implementation. Meanwhile, the Ministry of Communication and Information Technology as a coordinator of the national campaign has carried out campaign using various media, TV, radio, print media, online social media, to talk show and forums. One question again. For the question about supplementary food, Indonesia government provides supplementary food for fathers who are still breastfed by their mother. Also, the government provides food for elementary school students. The food is usually biscuit and porridge, which given during the school hour. Indonesia government also announced the importance of balancing food to teacher and parents, such as having macro and micronutrient such as carbohydrate, protein, fiber, and milk. And dan lain sebagainya. Ya. Masih banyak itu ya. Thank you.
Yeah. Thank you so much, Mr. Ahmad Djamil, for the explanation to answer the question. However, we know that actually stunting is being one of our current health issues in Indonesia, and all health workers still fighting to decrease the number of cases in toddlers. Okay. I will say thank you to all the speakers from Malaysia, Thailand, and also for Indonesia. And before we close our program, I would like to share our certificate symbolically to be given in this session for Professor Victor, Dr. Rapeepun, and also Mr. Ahmad Djamil. Congratulations for the certificate, and thank you so much for being keynote speaker in the second Strada International Conference on Health.
Thank you very much.
Terima kasih.
Ya, terima kasih. And
Thank you very much, everybody, for attention.
Jumpa lagi.
Matur suwun, terima kasih.
Saya mau datang ke Surabaya. Kita boleh sampai Surabaya.
Sampai ketemu.
Bila COVID habis kita pergi Surabaya.
Ya.
Kita datang Malaysia lah. Nah.
Ya. Okay. Thank you for all the speakers. Thank you to Mrs. Ratri Setio Mulyasari SKM, who has been conducted the session and also this discussion. So it's running well. And ladies and gentlemen, before I end our meeting today, I would like to share information regarding the registration of the new students of Strada Indonesia Institute of Health Science. Institute of Health Science Strada Indonesia has 3 faculties, namely Faculty of Health, Faculty of Nursing, and Postgraduate. The first one is Faculty of Health. There are some programs such as Diploma 3 Radiology, Bachelor of Public Health, Bachelor of Pharmacy, and Bachelor of Hospital Administration. And the second one is Faculty of Nursing. There are 3 Bachelor of Nursing, Nurse Profession, Bachelor of Midwife, Diploma 4 Midwife, Diploma 3 Midwife, and also Midwife Professions. And the last one is Postgraduate Program. There are Master of Public Health and Master of Nursing. And for information, more information, you can access in pmb.iik/strada.sc.id. So this is the end of our first meeting for today in International Conference on Health. And thank you for all attention and participants. And please, before I close, we will take the picture together. So please open your video to all the participants. Please open your video. Mohon semua videonya dinyalakan sehingga nampak untuk wajahnya. Kita ambil foto bersama. One, two, three. 1, 2, 3. One, two, three. 1, 2, 3. 1, 2, 3. Ini mau, Mbak Eva. Baterainya.
Okay. I will count 1 up to 3 for capture. 1, 2, 3. Next view. 1, 2, 3. Next view. 1, 2, 3. Sudah semua Bu Ratna? And the last, please. 1, 2, 3. Okay, thank you.
Thank you. Thank you for the all participant and also the keynote speaker. So this is the end of our agenda today. And before I close, I will announce some announcement to the participant for tomorrow. So you have to ready to join with the second symposium for tomorrow at 9 o'clock in Indonesia time. And the last I say, apologies if there is something less during our agenda. And we will see you again at the oral presentation tomorrow at 9. Thank you and see you. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih. Matur suwun.
Terima kasih banyak teman-teman semua. Terima kasih to all keynote speaker from
Terima
Thailand.
kasih.
Victor,
Terima
Pak
kasih Prof. Victor, Mr. Rapeepun,
teman
Mr. Djamil,
mahasiswa.
and also Bu Endang.